short overview. We'll talk about who we serve, how many people do we serve, and what do people receive when they receive services through DDA. And I will be saying DDA because Developmental Disabilities Administration takes entirely too long to say it about 100 times, so excuse me for that. We will also talk about the Waiting List Initiative, also known as the Alcohol Tax Initiative, and we'll spend a little bit of time talking about the progress to date. The last thing we'll talk about today is the DDA community waivers. Really just some of the waiver basics, and much of what we talk about will be the community pathways waiver and then the additional component of new directions. Okay? DDA's goals, just to focus on what our intent is our vision is that people with developmental disabilities will direct their lives, that they'll have viable supports and options, and have the information they need to make informed decisions. Okay? Basically what DDA does is we are responsible for implementing the state laws. We administer the programs for Medicaid, also known as our waivers, community pathways, and new directions waivers. We fund community services by way of our provider system or community services agencies. DDA is responsible for administering the remaining state residential centers and forensic residential centers. Okay. One of the things that is very important to remember about DDA is people who have a developmental disability are considered or shown to have a severe and chronic disability, and you can read that due to a physical or mental impairment other than the sole diagnosis of mental illness or some combination of impairments. The disability must be manifested before someone is 22. We assess that it is likely to continue indefinitely, and a very important piece here is that the person, aside from a diagnosis alone will not make a person developmentally disabled. But in addition, the person must show an inability to live independently in the areas of taking care of themselves, such as personal hygiene, dressing, being responsible for the health, basically, of themselves, taking care of a home in the basics, can do some basic cleaning, or at least knows how to get help if they need that, knows how to keep the doors locked, basically, the essentials that we need for taking care of our own apartment or place, or room, for that matter. And then community, getting around the community. It doesn't mean a person needs to be able to drive. What it means, though, is a person, if they have to get to, say, a doctor appointment or something else, they can either get there through public transportation, know how to access people or other systems that can help them get to where they need to go. And that there's a need for ongoing individualized special care, treatment, and intervention, which really means that there's a need for an interdisciplinary or multidisciplinary approach to look at the person's whole life and help them navigate through their life as a team. Okay? All right. Then there's the other, probably not as well-known piece, the people who have disabilities that do not qualify as a developmental disability. This is known as supports only. Some of the same criteria exist, such as a severe chronic disability, as you read in the developmental disability. This situation or the evidence may not have occurred before the age of 22, such as a young person that's in a car accident at 24 and undergoes a traumatic brain injury or something. They may not meet the criteria and the functions of limitation for self, home, and community. Again, you have to show significant limitations in those areas. And a person that supports only may do very well at taking care of themselves and getting around the community, but they need a whole lot of help in taking care of their own place. And they may or may not have the need for ongoing specialized interdisciplinary team and individualized services. need people in our lives. We can't function, live independently. So we don't say as soon as you need a body in your life to help you do something that you suddenly need full developmental disability, that you meet that criteria, but it's a degree issue there. Okay? Right. Many of you probably know that we look at the DDA when someone is designated to have a developmental disability or supports only identification, that there are priority categories when someone goes on the waiting list. Those primary categories are crisis resolution, crisis prevention, or current request. The crisis resolution is an emergency situation. Emergency may be today, or certainly will be an emergency over the next 30, 60, 90 days. Crisis prevention, however, is either you have an elderly caregiver that we know something's going to happen over a period of time, maybe in the next year, maybe shortly thereafter, or that your situation is going to turn into a crisis situation over the next year if preventive services aren't put in place. And then current request is really people that, hey, they could use services. They would want services. And if we can, if we have the money, if we have the funding, it would be great to be able to provide those services, but they're not in urgent need. Okay? And I don't keep saying okay because I'm asking the question as much as I'm asking for the slide to be turned, so just so you're aware of that. What do people get and how many people get that? At the moment, more than 20,000 people in Maryland receive some services with DDA. And as you can see, they're, at the very least, people tend to receive resource coordination, but they may get what's known as family or individual support, some what we'd call the residential or traditional residential kinds of programs, supported employment, day programs, competitive employment with a little bit of support, and then what we, many of you know as low-intensity support services, or LIS. At the moment, less than 100 people are in crisis and waiting for urgent services, which has not always been the case. About 6,000 people are on the waiting list in what we would call, again, the crisis resolution, crisis prevention, or current request. Okay, that is what I wanted to talk about as a quick overview for DDA. But I want to give you, before we move on to waiting list initiative and the waiting list cleanup, I wanted to give you the opportunity to ask any questions or make a comment.
So the best way to ask a question is there's a little hand icon on the left under the participant list above the chat box. So if you have a question at this point about what Cindy just presented on, you can click that.
Also, Carol,
you should mind that
because
they're not connected
through their
actual login name,
I'm unable to tell
who to unmute. So
I think it may be better
to send the question in chat.
If you're not connected with a little telephone next to your name, then we won't be able to let you talk because we won't know who you are. Okay. I guess we could unmute everybody at once. So, okay, it doesn't seem to be any questions, so we can just move on.
I was either that clear or you knew all that information already, so we'll move forward. Can I change slides? Okay. We mentioned the waiting list. People get determined DD eligible or supports only eligible, and generally they're going to go on DDA's waiting list. Several years ago, actually in 2008, we started asking and were being asked, so who are these 19,000 people on the waiting list? And not only who they are, what do they need, what kind of funding do they want, and is there anything we can do for them? And frankly, I hate to admit it, but we had very little clue as to who these 19,000 people were. So what we did is engage in a waiting list cleanup. And there was a lot of pressure to do so, partly because of these questions. We weren't the only ones asking these questions. Self-advocates were, the advocates, the governor was asking. Everybody needed to know the answer, and we knew we didn't have those answers. We looked at this as, to engage in the waiting list cleanup as an opportunity to start getting some consistent determination process across the state, because we recognized that there were variables among regions at times, that the opportunity was there to improve the DDA process for eligibility determination, which I think we engaged in very strongly, to establish an ongoing review process of the waiting list, so it didn't just sit there and grow for 15 or 20 years and hope it got to the right people that needed services, and an opportunity to focus on an effective data system for planning, both what we needed to do right now and what people are going to be looking for in the future for us, 2 years from now, 10 years from now. Okay. We knew that we could only take advantage of these opportunities and answer any of these questions if we engaged in the, believe me, arduous task of cleaning up this list. Okay, Brian? All right, back in 2008, we started planning this thing, and about 3 months later, very confusing, but a whole series of letters and phone calls occurred. To the central region alone, we've calculated that about 15,000 letters and follow-up phone calls occurred during this period of time and over the next year. Now, we happen to be the biggest region. We're about 50, just about 49% of the overall state, but you can probably double that to get the picture of how many letters and phone calls occurred. And I say that for a couple of reasons. One is staff are very busy, and the other is when you take on that volume, we confuse people. And so we recognize that some of that occurred. That's why we did so much follow-up in phone calls and tried to respond to people, because they were highly confused, and in some cases the wrong people got some wrong letters, and we tried to rectify that. But what it gave us is that we started validating that information in January of 2009, and we continue to do that today. And then twice a year we've committed to getting a real good handle on that moving target, which of course the list will always move, and a report on those stagnant numbers for that day in January and July to continue to give us a picture of the waiting list. Okay, next slide. The new waiting list reflects only individuals not funded for any service, and that was something we thought long and hard about, because we have a lot of people in services that were getting maybe some day support, but they really wanted or needed residential support or some sort of residential program or something else. They may have been receiving support services but really wanted day. But our intent was these people really weren't waiting to get a DDA service. They were needing additional services. And so we tracked those separately, and I'll show you on a slide in a minute. But those people actually came off the waiting list because it skewed. It made it look like all of these people were equally waiting for the same kind of services as everybody else. So it didn't give us a true picture of who was new to the system. We maintained the 3 determination categories on the waiting list: crisis resolution, prevention, and current request. What wasn't on here anymore that used to be was what we would call future need. And that was really looking at people that were at probably more than 3 years out. They wanted their son or daughter or themselves to be on a list knowing that sometime in the future they might absolutely need services from DDA. So we pulled them off the list, and it's a registry, because there's nothing to give those people right now except to be there in the event their situation changes. So that is your future need list. All right, change. All right, we go to people in crisis. Keep in mind that we're talking about people that either today need to be picked up from the hospital, or something has occurred and they are in immediate crisis and need help now. 2, people that we know they're either homeless and it's going to be an immediate crisis within 90 days, that the caregiver may be unable to provide adequate care either through age or health or just emotionally, so they're done, that physically they're at risk for harm where they're living, or physically they are at risk of harming others due to their living situation. Those are the people that get that target designation of crisis resolution. Okay. Next one. If you see the little pie here, the waiting list is made up of the people that we just mentioned, those who are literally on the waiting list either in crisis resolution, crisis prevention, or current request. They want something, it's not urgent, they can wait, but they do want services. The people in the future need registry is a database that's still tracked. And it's tracked, for instance, we may have a 16-year-old child that as they leave school at age 20 or 21, it's very clear that they're going to need day services and will probably be eligible as long as we have the governor's waiting list initiative, our transitioning youth initiative for those that just get out of school. So we track that to see who's coming. So when they hit 18, they're going to go on to that current request list because we don't want them graduating and then finding out at that moment, oops, we should have known they were coming. So we checked out future needs registry for those kinds of things. The service registry is what I talked about a minute ago when we look at the number of people that are in service wanting or needing other services. And one of the reasons, again, we did this is because under any of these people that are served through the waiver, and we'll talk about that in a little while, we must provide those needed services. So we can't have them hanging out on a waiting list. So we look at those through a different database. And then, unfortunately, we have a hefty inactive list. Those are people that, out of those 15,000, 30,000 letters, multiple phone calls, cross-checking with Medicaid records and service coordination and multiple other ways, we tried to find these people. And the addresses or contact numbers we had no longer are accurate. So when we cannot find the people that we knew about before, they go into the inactive list. Trying to tell everybody and let them know that as they recognize that they're left off the list or they need something and DDA is not there for them, when we learn about them again, we immediately reactivate them and they come back on the waiting list. But we needed to separate them out because there were many people that have moved, moved out of state. Unfortunately, some passed away, and there was no way to reach them. So were they really waiting for services? We don't know. So as we find them, we're putting them back on. Okay, Brian? All right. This is the part that gets real exciting. Because we had a waiting list that we absolutely can look at now and say, we know who these people are. I can tell you every person in crisis resolution in Central Region, not only who they are, but what their needs are, how urgent their crisis is, and the fact that we're working on getting them services as we speak. I can tell you some of that for crisis prevention, but service coordination and my staff are beginning to know those people pretty well. And then you have people at that current request level that we're, again, following the database even if we don't know them that well yet. But thanks to that clarity and thanks to the interest and priorities of tons of stakeholders, the self-advocates, the advocates, the providers, the legislature, our own staff, Senate Bill 994 is the sales and use tax that the advocates were extremely successful in getting passed and given support to DDA beginning this year. It's the alcohol beverages. You may hear about it, about the alcohol initiative, and certainly the waiting list initiative. There was a supplementary appropriation. $15 million was given to fund the waiting list in years that, keep in mind, were very, very tight financially. $15 million was appropriated to DDA beginning fiscal year 12 for two reasons, well, a lot of reasons, but two priorities. The priorities for people on the DDA waiting list in both the crisis resolution and crisis prevention priority categories. What's exciting about this is we've known that we have to try to keep people off the crisis resolution list and get them into services as soon as possible. A lot happened to get them at that very critical stage. So while we always strive for that, we have not always been successful at trying to get at those people because of money. This allows us to start doing that. And so I would like to say that very successfully at this point. The other really awesome thing about this initiative is that it's recognizing that if we can get in there and help families, help people with developmental disabilities or support-only issues, prevent a crisis, they may never hit that crisis resolution list. They may, but if we can do some earlier intervention, we know that we can often minimize the need for crisis services, which are very emotional for the person going through that themselves. Not to minimize also that it's way more costly for DDA, but certainly most costly for the person that's in that situation. So beginning July 1st of this year, we had the green light to go spend this $15 million and spend it wisely. You can go to the next slide. All right, our guiding principles that have been very clear from, again, all the stakeholders that help make this happen is that we spend the funds as the legislature intended, focusing on crisis resolution and crisis prevention. Given that the significant unmet need is for crisis resolution, $15 million to serve people with developmental disabilities, which is a little bit of a misnomer because people with supports only needs also are impacted by these additional funds. Our other guiding principle is that we maximize the use of the state general funds with the federal match, which is why when we're done with this, we're going to move into the waiver services for a couple minutes. Next slide. Excuse me. All right, beginning July 2011 to January 2012, I will back up from that date just a little bit because even while we knew the appropriation was successful, we knew that back in April, I guess. We knew the success of that and that we were going to be responsible for being good stewards of $15 million for people in crisis resolution and crisis prevention. We made a commitment with our existing allocations last year to start getting folks that we knew of in crisis out of crisis. So people, I believe at that time, and I do get my numbers mixed up once in a while because things are moving so fast, but last winter we had probably 150, 160 people that we definitely knew were in crisis situations. Some of those people already had services before the waiting list initiative alcohol tax use dollars began on July 1st. From July 1st through now, I can tell you that my region had about 100, probably 8, depending on the day. We now have 32 people in crisis resolution in central Maryland. We probably we're down to about 70, I think. That one don't quote me on because, again, it changes as new people come in to crisis and as we get people served. But we're very proud of the fact that July 1st, with the start of this, we now are down to 30, I believe it's 32 or 34 people that need critical services, and none of them are sitting there with nothing happening yet. That they are in the planning stages, they've already picked providers, or in some cases they've already moved and are starting services. So, let's see. Okay, so our intent is to get everyone in crisis resolution into the services and supports that they need. People in the crisis prevention category become a next priority as soon as we can, what we would call clean or wipe out the crisis resolution list, but I'll be real upfront with you, it will never be wiped out because we get new people every month. Unfortunately, they're facing some sort of crisis. So it will never be gone. It will always be a little bit of a moving target. But if we can prioritize those folks and get them into the services that they need, we then, beginning December, or January, I guess, are going to be able to define how much money it will take to continue to spend or to support those people in crisis resolution, knowing that that money becomes what we call annualized money. We also can't project exactly how much that will be, so we have to watch the folks to see where the costs are going. Over the next couple months, that will give us a sense of approximately how much we will have left to then be able to spend on people what we call in the crisis prevention category. So crisis resolution, that's fine. Crisis resolution is full service, everything that the person is going to need to resolve that crisis. Crisis prevention isn't going to be quite so free-flowing, but we're pretty excited about it because we think that we're probably targeting at least what we call services of short duration, where people and their families, individuals and or their families, can get services that might be the purchase of adaptive things for their house, big ticket items. It could be ongoing support. It could be major respite care for the family to get away, or it could be major respite care for the person to get away from everybody else so they can have a break. But any of those kinds of things that a short-term fix may help over the long haul. We can't say there won't be any new money to continue the funds for people with crisis prevention. But we have to plan on the fact that the $15 million is the only thing that's going to be ongoing. So people in crisis prevention will get a lot of support, but it may in fact only last till July. I did mention that the crisis resolution list will never go away. We estimated that 11 people will become eligible for the crisis resolution category each month, and that's statewide. That's not just in the region. But I have a little however there, because since the waiting list initiative, we have people are on a higher alert, and we have had more people enter the crisis resolution ranks than we normally might, so that my region is probably experiencing 11 a month. So we're possibly looking at about 20 people a month statewide that are coming into crisis resolution. Okay. The action plan is to assure that each person that's getting services absolutely has access to a resource coordinator for people identified. The people in crisis resolution, again, get comprehensive services. Our job is, if someone comes in today, in fact, this happened yesterday, I got a call from a hospital, and the person basically cannot go back to their home. They're stabilized in the hospital. They can't stay at the hospital. In the past, it could have taken weeks until we determine who's responsible, where we're going to find the money, where we're going to find the resources. We know that this young man is 19, so a provider wants to provide respite services for him. We had that in a day. He could have moved yesterday, except that he's 19 and he's going to be in respite in a home where there are 21 and 23-year-olds. That requires a waiver through the DDA license. So that will take a couple days to get the waiver request written and approved, and the provider prepared. But basically in 4 business days, this young man will be living in an emergency respite situation with the provider then preparing to serve him long term. That's the intent of what we're doing now, is to expedite everything we can, expedite the payment process, expedite the, in some cases, the eligibility process if a person is left at a hospital or in jail or something else, and really get them at least the Band-Aid services up front. then that will afford us the time to do some long-term planning. People in crisis prevention are not going to get the comprehensive services, but they will get what we call the short duration, and probably equates to if you are familiar with family support services or individual support services. Okay? The target group for services of short duration are people in crisis prevention. And the guiding principle there is given that people on the DDA waiting list are at risk of crisis within about a year, that we want to provide funding to prevent these crises where we can. Depending on ongoing allocations, like I said, this may be one time only, maybe not. Okay?
Okay, we have a question. We have a question here, and the question is, how does a person get on the crisis prevention list?
Okay. The crisis prevention list, like the crisis resolution or current request, if the person is already on a DDA waiting list and we know of that person and have identified them as either supports only or developmental disability, if their needs have changed to where it looks like in a short period of time or about a year, things are going to get a little crazy and crisis may occur. Again, if they're already on a list but not in that category and things are changing, if the person has a service coordinator, the service coordinator should be contacted, and that person, the service coordinator, will then submit to my office a CNR or critical needs update. With that update, then my eligibility team review it for the urgency. Does that person now qualify for a potential crisis over the course of the next year if we don't do anything? If they are currently not on the list at all and you aren't sure that DDA even knows this person or they haven't been determined eligible, then I would suggest that that person go on the web or call DDA, any of the regional offices or headquarters, and get an application. But you get on the crisis prevention list by those conditions of, when we looked at potentially homeless, potentially at risk, potentially, as caregivers, frail health, but it's not today. We look at those things that may be happening over the next year. I hope that helps.
Okay, and Brian, it looks like Sandra Spears has a question. Oh, okay, Sandra, go ahead.
Okay, hello, I think I just sent it, or can you hear me?
Yeah, we can hear you. You can ask. Go ahead.
Okay, well, my question was, is the $15 million renewed annually? And I had another, is there a limit to funding allotted for any individual? Or what is the limit? I would imagine there's one.
Okay, there really, I'll go backwards. There really isn't a limit for people that are in the crisis resolution category. It's based on need, so the person's not going to get an unlimited budget, but with the evidence of need, both through waiver services or state-only funds, we will do what we can to meet that person's needs. So in essence, there's not a limit. With people in the crisis prevention category, there may be a range, but it's still, someone may ask for a $2,000 purchase and be fine. Someone else may need $20,000 or $25,000 for like services.
Okay.
Then your first question was, is it ongoing? The $15 million is a one-year commitment for new services. But as we serve people in crisis resolution, keeping in mind if we spend $10 million of it on people in crisis resolution, those are ongoing services, so that money needs to be annualized. So it won't be $15 million new dollars. It would be that portion that goes to support those people year after year, which is why we can't work with the folks in crisis prevention until we have a sense of how much of that crisis resolution money we'll be using.
All right. Thank you.
Okay, and earlier we had a question, and I think that because we have so many people who are call-ins, and I'm not sure that they were able to read the chat, The question was, do any of the DDA wait list initiatives relate in any way to the autism waiver wait list?
The wait list, not directly. However, we are involved with the autism wait list as far as certainly students aging out. So we are aware, for instance, in fact, I just had a conversation with Boyd Pusey at MSDE, who tracks the kids with autism, and we're very aware of the numbers of children that will be coming over the next couple years. They separate separately. They're operated. They're administered by two different entities, two different administrations. All waivers are Medicaid at the start, at the home base, but they may be administered. And so today, unfortunately, I'm not the expert in autism waiver, so we won't be covering that because it's not a DDA.
Right. The autism waiver is an MSDE program, and we actually did have a presentation on it, and I think it's still on our website. We're in the process of changing our website, so it may have been taken off, but if anybody wants to email me, calenza@mdcoalition.org, I can get it to you. Okay, we have a couple more questions. Okay, right there. Are there any additional initiatives to assist families and caregivers who are now spending more time and money caring for family members while it is becoming more costly, but everything is being reduced? And I think you mean everything is being reduced as to, I guess, access
Giving,
to services.
foundations, probably
right.
everything. Services. I wish I had a better answer for you. That is one reason that we have the low-intensity support services that certainly serve some purposes when families can't get help in other areas, or people living on their own can't get the help. We have individual and family support services that when you're receiving DDA services, we try to be as helpful as we can. Part of we're really stressing the service coordination or resource coordinators, because we're putting a lot of focus on help people find generic or other services, because while everybody else is experiencing the tightness of money, so are we.
Okay. Can the family, and I think this is a follow-up to the question before, can the family express a need, or does a medical provider have to justify the crisis?
No, the family certainly can. In fact, in most situations, we would look to the family or the person themselves. I mean, we certainly have people call their service coordinator and say, I'm in a mess. I need help desperately. And the service coordinator will sit with them, try and write it up in a way that can clearly state what's going on. But much of that information comes from the person or the family. A physician or others may be used to discuss something technical, but no, it's most important coming from that person or the person's family.
Okay, and the last question, although the autism waiver is under a different division, do you know if there are any plans, any plans or consideration of an adult autism waiver, considering the fact so many people were not served in the regular autism waiver since it was so long?
I think it goes back to it's a different administration. So as people come out of the autism waiver and need services as an adult, that they would be subsumed under DDA's existing either waiver. If they were waiver there, they'd probably be waiver eligible for DDAs, or under the state-only dollars, depending on what category they fit. I will say one thing, while it's close, it is not automatic that if you qualify under the autism waiver that you absolutely would qualify for DDA services. Again, the eligibility can be slightly different. So just because a student has autism doesn't automatically mean they're going to qualify as having a developmental disability. Many will, but some don't.
Okay, another question. You mentioned at some point student-aged individuals will be moved from future need to current request. Is that automatic at a certain age absent external circumstances, or is it the responsibility of the parent to ask for their child to be moved from to current request?
Good question, Marnie. Ideally, we are getting good enough eventually that we're tracking the future need registry to be able to look at age of caregiver and age of the student, so that we are looking at that. We're not yet probably smooth enough to catch them all. We're still noticing some kids coming in that were our transition age that for whatever reason the school system didn't let us know or we didn't know. Is it a good idea for the families to let us know? Absolutely. It's a real good idea for them, especially a year out from the time their child starts school that fall before they graduate, or if they're going to be 21 through the school year, and that will be their last school year. It's only going to help us and help them if they also do the contacting, but no, we are looking at the list.
Okay. This is a quick answer, and I already answered it directly, but it's a good thing for people to know. Do you have to be known by DDA to receive listserv funding?
No. You do not have to be determined eligible. You have to likely have a developmental disability, but you don't have to be, certainly not, you don't have to be receiving services from DDA, and you don't have to be known to DDA. The providers that we have doing the list are, they're going to ask for some evidence that shows that your child or your family member, the adult, has a developmental disability or probably has one, but that, you know, it's not dependent on you being designated. Now, I will say it gets complicated if someone has applied for DDA services and has been determined not eligible. That would then imply that, well, in fact, your family member, you don't have a developmental disability, therefore you wouldn't be eligible. But beyond that, no, you don't really need any involvement with us at all.
And actually for children, I know in the past, and I don't know if this is still continuing, a copy of the IEP was sufficient evidence of a developmental disability if it says that in the IEP that there is a developmental disability, whether it's autism or cerebral palsy or some of the others. So I know that's been sufficient. For adults, generally they've my experience is they've asked for letter from the treating physician, psychiatrist, whoever is involved with the child, the young adult or the adult.
Let me just add to that. It gets a little difficult and very frustrating for some people because, keep in mind, students with a mental health diagnosis also have IEPs, and students with some disorders that really won't result in those functional delays, functional limitations, or fit the criteria for DD. So an IEP is certainly used. We look all the time at the IEP. But in itself, it may not be the proof for a person to qualify. Same with any psychologicals or psychiatric evals. Very often we have an IQ score, but we have nothing that shows the functional limitations, and then you go and meet the person and find out they've been living on their own for 5 or 6 years with a little bit of help from mom and dad, and really have made their own decisions, controlled their own life, and certainly could use some support, but they don't need full DD services, nor do they meet the full criteria.
Okay. Are we planning to have a one-stop system where each agency can link in to find all those who need help instead of people falling through the cracks from not being on different lists? I think
Probably from
being on different lists.
What a question. I mean, that's absolutely the question of the decade, probably. I can tell you, as most of you probably know, DDA has a new executive director, Frank Kirkland. Frank and I would say most of the people in DDA and in DHMH in particular are hopeful that the systems can come together more and more instead of, uh-oh, he's DD, uh-oh, he's mental health, uh-oh, he's substance abuse or something else. That same commitment is there, I believe, from, say, vocational rehab. It's there from NSDE and social services. However, there's no unifying source at this point. And so it's going to be slow. And again, like everybody else, I think we're all fighting for a little bit of resources. But I guess the long-term answer is we don't want it to be difficult for people and or their families. So ideally, we want to make that come together. I can tell you within Department of Health and Mental Hygiene, that's a fairly high priority. How we get there, I don't know yet, but we're working on it, and we're working hard on it.
Okay, I think that is it. Okay, I think we can move on.
Okay.
Thank you. Great questions.
All right. So given all this, we come to the third section, which is how do we pay for this? And does anybody really care? Well, yes, as taxpayers, we all care. And certainly as people that know someone with a disability or you're a family member, this becomes very important because it helps determine whether there will be or how there will be dollars available to pay for these ongoing services. Okay? Many of you may know this, but I think it's important to explain. There are two ways that DDA funds services and supports. One is state-only. The people in the support-only eligibility receive state-only funding. People that do not meet the technical, medical, or financial criteria for waiver services, so they may have a full developmental disability, but they don't meet some of the criteria needed for the federal level of waiver services. Other people that receive state funding is, those are the two primary. Other people that receive it are some that may come in and we don't quite know yet what their level of need is. In the past, they weren't, children in fact, weren't mandated to apply for the waiver. Some people used to have the choice of, no, I don't really want to apply for Medicaid. They would get state-only services. That no longer exists for a couple reasons. One is, in fairness to people, if they're eligible for the waiver and they meet all the criteria and we have the so-called slots available to put people in, then they should be able to access waiver services. The other is we no longer really feel that it's fair to us, the taxpayers, and other people who have applied, for someone to say, no, I don't want to share my financial information, so I'm not going to apply. That is something that people are required to do. They must apply for Medicaid and Medicaid waiver. Keeping in mind that state-only funding is very shaky because it's totally dependent on the budget allocation from the General Assembly. So when you ask the questions about dwindling resources, we're as affected as everybody else. And that's why it gets real tight and real hard for families, because we are in an age of dwindling resources. The second way we fund services is through home and community-based waiver funding. These people that have waiver services do meet the technical, medical, and or financial criteria, which means they also have a developmental disability. Waiver recipients are entitled to services. Support or state-only funding is no entitlement. If the money dries up, I may not be able to fund. Federal, they don't care if the money dries up. I still have to be able to pay for needed services. Okay. Why Maryland has waivers, any of you that know autism waiver or anything else are probably well aware, through a waiver you can serve more people because you get money, a matching amount from the federal government. Medicaid is a matching program. The state pays part of the cost and the federal government pays the rest. And there are different formulas in different states depending on multiple factors. But in Maryland, our match is about 50% for our waiver. The number of people that can be served through our waiver is dependent on how much money the state can match. So where it appears, okay, I'm eligible for the waiver, now I got in the waiver, isn't always the case. If we have 10 what we call slots, and you're the 12th person and all 10 are filled, you may be waiting for a waiver slot. Maryland is pretty good. We stay in pretty good shape with that, but at any point that can happen. If we hit the number of slots we have allocated, because of our state match money, we may be on hold as to new people getting in to waiver services. Next slide. All right. Oops, I don't like when I do that. I have a little Maryland up out of the box. Maryland has 2 waivers. Most of what we're going to chat about is the community pathways because it's sort of the umbrella. It's the overall waiver. New directions, we'll spend a couple minutes toward the end because it's, I think I even alluded to, on the slides to it being a supplement or alternative. It's a secondary waiver, but it is all-encompassing. Community pathways are our main waiver. So community pathways is what we're going to talk about mostly. It is a comprehensive waiver. It includes resource coordination, family and individual support, some of the things I listed before. Traditional residential could be a group home, alternative living unit, could be family care, could be a person's own home, what we call CSLA or community supported living, employment support, day habilitation. Generally, community pathways waiver services are coordinated through provider-based services. That's where you hear of the ARC of Howard County or the Chimes or the ARC of Central Chesapeake. There are about 210 of them across the state. Providers are paid through Medicaid to provide these more comprehensive services. Maryland's community pathways waiver serves about 12,000 people. Keep in mind we have about 20,000 or a little over in service of some sort. 12,000 of those folks receive waiver services. The new directions that we'll touch on toward the end is an Independence Plus waiver. What designates it as different is it is also comprehensive in many ways, but it's self-directed. Only serves about 200 people at this time. I will tell you that before we even go to the specifics on it, the New Directions waiver has been phenomenal for some people, but it's real tough navigating the application process, getting everything in place. There are horror stories about it taking a really long time. DDA and some outside folks are looking at how to streamline that process and make it more user-friendly. I'd like to see that. I think we'd like to see that doubled or tripled in the way of people doing more self-directed services. Okay, next slide. If you look at operating a waiver, understand these are Medicaid waivers, so Medicaid is the responsible administration. However, other administrations may be operating those waivers. So in order for us to operate our 2 waivers, as part of the state, we need to ensure that people meet that medical, financial, and technical eligibility. They need to meet Maryland Medicaid eligibility. They need to meet what is called the level of care for a nursing home, ICF, MR. I hate using that, but the national term has not changed with that yet, through hospital or Medicaid-financed institutional care. So they must meet that level of care, which is why people in that supports-only category would not be eligible for waiver services. The state must assure, I'm sorry, I did an okay as part of talking. Sorry, Brian. The state must assure health, safety, and welfare and have a statewide quality assurance system. We must ensure that people have freedom of choice, that they can, in fact, choose to live in the community or an institution. Doesn't matter if I like that or not, but they do have that choice. To choose among qualified providers so that they cannot be steered to this is the only provider that can give you that, that will allow to give you that service. And the state has a responsibility to make that waiver cost effective. There is an aggregate amount across the state of Maryland for our community services, and there is one for ICF-MR level of care. Our average cannot exceed that cost, that average of institutional care. or we will have to regroup, cut costs, do something. But we cannot exceed that cost. So in some cases, you will see someone that requires services that we cannot provide. Either the waiver doesn't pay for it, allow us to, or our aggregate cost, which we're not in danger of doing right now. But if we exceed our aggregate cost, then we have some regrouping to do. Next slide. Getting service once you're enrolled in a waiver. So you've already been determined DDA eligible. You've filled out the waiver application. You've filled out Medicaid. You've filled out the waiver application. Congratulations, you're eligible for waiver services. The getting services is the beginning part is the IP or individual plan. This plan needs to include all the services and supports that you need that have been assessed as one of your needs, including services that are funded from other sources, such as generic sources and community programs, Medicaid, state plan, or private insurance, other public programs, school systems, social services, DVR, wherever they exist, through and also through the provision of informal support. So what can friends, family, and others provide? This is a requirement. It's not just DDA wanting to be cheap. It's DDA having to meet this requirement in that service coordinators and the person and their team must look at other services and sources of support. Waiver services complement or supplement their services. You will hear from us, and you will hear from some, I just got distracted for a second there, that you will hear from other sources that, well, we're the payer of last resort. Now, any waiver services generally are going to be the payer of last resort, so we will have to show that we've looked at other places first. Next slide. The state is obligated to provide all people enrolled in the waiver the opportunity to access all needed services. The next two bullets are very important. The opportunity under the waiver is determined in need on the basis of an assessment and a written plan of care. It's got to be documented that there was an assessment, that there is a written plan. This doesn't mean, however, that all waiver participants are entitled to receive all services that could theoretically be available under the waiver. It is based on need, not as much based on what I want. So hopefully a lot of those things, I want a quality of life. I want safety in my life. But, if I see the waiver services and say, yeah, I want one of those, that doesn't mean you'll get it. If there's an assessed need that is going to help increase your quality of life and your health and safety, then yes, that would be available. Next slide. Okay, just some of the things that waiver services do pay for, and I was very cautious, or actually I was very concerned about putting this list up because, one, this isn't an exhaustive list, and two, it just doesn't mean that, here you go, pick off your menu. But these are the types of areas that waiver dollars can be used for. You see assistive technology can help with adaptive equipment or assistive communication kinds of things. Behavior support is able to be provided when needed. Resource coordination, any person receiving waiver services must have a resource coordinator assigned to them because there are very specific roles that the administration is responsible for, and one of those is the resource coordination component. Accessing community or transportation to get around in the community, learning about the community. There are, I mentioned CSLA, Community Supported Living Arrangements, and there's a component in there that pays up to 21 days. Say you go to the hospital, you broke your leg, and you're going to be in the hospital for 2 weeks. It can pay your staff member to be a support to you in the hospital, especially whenever people, it's a scary place, and for a lot of people that can be traumatic, and having someone there that knows them can certainly help, so it will help pay for that. Rehabilitation types of things, or employment. And employment discovery is, I can't apply for a job yet because I don't even know what there is out there. So I can get a time-limited period where staff can come around and help me check out what kind of work do people do, where is work, what are the kinds of things that people do whenever they have a job. Next slide. Okay, the other kinds of things, we mentioned family and individual support. Somebody needs a ramp or some of the environmental modifications. There's a caveat about live-in caregiver rent under certain models. If my caregiver is going to give me basically gratuitous service, but I'm going to give them free room and board, I can actually get some support for paying that person's room and board. Can't pay mine, but I can help pay for a caregiver that's going to give me some gratuitous service. And then there's support. I must have a support broker if I'm in new directions. Community Pathways does not have support brokers, and a lot of times people coming out of either their own family home or out of, say, a nursing facility or other place has nothing. They may not have basic furniture. They may not have. Recently had a young man that his caregiver had passed away, and it was the house, all the belongings were held up legally until everything could be resolved. He was hospitalized, and he had a toothbrush and a toy. He had nothing else. The waiver dollars can help with some transition funds to get people some of the basics. Keeping in mind that much of the waiver support goes towards staff to support people. Next slide. And what we can't do in any waiver is give cash directly to a participant or a parent. We cannot pay for room and board except for respite. We can pay for some meals. In fact, it stipulates 1 meal a day on Meals and Wills or something like that, or that caregiver option that I just mentioned. We cannot pay for the same items that are covered with an MA card. MA card must cover first. If it doesn't cover that service, then we can look at it being picked up through waiver funds. We also can't pay for other services that are covered by entitlement services, such as MSDE. Education services are an entitlement, and we can't supplement those, nor can we with vocational rehab. We can pay for different services, and we can pay when funding is done, but we can't pay for repeat services. And I know this hurts a lot of families. I think especially families who have children with autism that we know benefit from different kinds of interventions and educational supports. While they're in school, I can't pay for those. I can't pay for supplements or augmentation to those things. Let's see, pay for recreation, guardianship, or institutional services. You notice I say therapeutic recreation is okay because community integration is a component of where the waiver wants people to go, how to be a part of and integrated into their own communities. So there are some of those things, those very items that we say we don't pay for, that can fall under community integration. One, if it's therapeutic and if the assessed need is there. Can't pay for home repairs. However, we can pay for repairs if there was an accessibility issue. Next one. A person's right to receive a service is dependent on finding that the individual needs, based on appropriate assessment, and that the state develops and applies fairly to all waiver enrollees. Therefore, waiver participants have a right to service changes based on need. Okay, so I come in, I'm on the crisis resolution list, and I need a full residential placement, and I need to be in an alternative living unit because that's the level of support I need. My life has changed a little bit, and I want more control of my life. I want to live with my best friend. We want things to happen differently for us, and my needs have changed. Next slide. In the waiver, this is only about just over a year old, but I think has made a dramatic difference in how we get to those services that people are entitled to that are in waivers. There's a request for service change process, and it must come through the service coordinator. But if the person says, you know, I've been in this group home or this alternative living unit, and I want my own place, I want more control in my life, I don't need quite the same level of staff that I needed before, but I still need a lot, and my roommate and I want to live here. Okay, DDA cannot pay for where that person wants to live. Those resources need to be found through housing, through their own income, whatever. But we have a request for service change process that reviews every request when a person wants to change either the way their budget works, the way their services work, or who gives them to them. In doing that, the service coordinator, like I said, has to present it. And if you look at the request for service change, it says, these are just examples of, you know, I want to move to another provider, or, you know what, I want to stay with my provider, but I want to move to this supported living kind of process that they have instead of that group home that I've been in. Or because I'm getting older or more frail, my needs have changed and I need more support than I ever did before. And believe it or not, in many cases, we have people saying, I don't want this level of service, I want more independence in my life, and so I don't need that same level of service, so I want this reviewed and have my budget reflect those changes. The Resource Coordination Agency, as I said, must show that the person chose these changes. The team cannot decide that for the person, except through a team process. I mean, if it's clear the person wants the support of that team, then we take the word that that team knows, about the best interest of that person. They need to show the evidence of the need, and submitting supporting documentation is very important. Waiver participants and their representatives may have the right to appeal. Okay, you submit that request, and the 4 regions have very slightly different ways of reviewing it. What we consider in reviewing these requests are all the same, but my region is so large that we have a review committee, and we get a tremendous amount of requests in, and it takes us a little bit longer. Maybe the Eastern Shore and Western Maryland, they have about a 1/5 of the volume that we have to deal with, so they don't need a full-blown committee to review, and they assign a staff person to do that. So you may see differences in that part of the process, but the criteria that we use and the determining factors and how we fund are consistent across the 4 regions. But at any point, there are times we deny a request, and usually it is either denied because the waiver services don't cover that someone's asking for, or they've asked for a wake overnight supervision and there is no evidence showing that anything's changed or that the person needs it. So when it's denied, the waiver participant is given a denial letter, and hopefully with a clear enough explanation as to why they're denied, and given the option to appeal. They can appeal either informally, which goes through the Secretary Sharfstein of DHMH, or they can request a formal Medicaid fair hearing before the Office of Administrative Hearings. There's pluses and minuses to both. Informally, we can often take care of the issue before it gets to hearing to make sure there were no misunderstandings or we could get additional information. In the little caveat at the bottom says you can actually request both. That's certainly the prerogative of the person. Sometimes they don't want to go through additional meetings, processes, and hearings, and it does take a good bit of their time, but that is certainly their prerogative to request both. Next slide. Okay, we're going to wind down here. I think I'm okay, and new directions was the little caveat I wanted to talk about. Keeping in mind that to be in a new directions waiver, you must have full DD services. You must meet the same criteria for eligibility and the waiver. and to know that each of the 4 regions has what we call a new directions coordinator, so somebody that can walk you through that process. I will tell you, it still takes a lot of walking because it's a very lengthy, time-consuming, detailed process. But, again, it works very well for some people, and we're hoping to streamline it. Next slide. About done. You can read that for yourself, but basically, if any person of any age, this person needs to want to self-direct. And in some cases, that's family that wants to help that person self-direct. Anywhere in Maryland, why would somebody want to do this? Mainly because they want more control and responsibility. Comes with both. They want the flexibility. It's more flexible than the traditional covered waiver services. They have to pretty much want to be able to hire and or terminate their own staff. When it takes time, don't be in a hurry for it to switch to new directions. You get the okay from the new directions coordinator, and then things can move forward. But again, I am hopeful that we're going to have that application and development process streamlined over the course of this next year. I think we're about done. One more. Okay. Also, if you're in new directions, you need to be willing to take on some financial accountability, but you do need what we call an FMS, fiscal management service, and support broker to work with you that makes sure everything stays legal and helps you make some decisions that may be a little beyond most of us in the way of labor laws and tax laws and all of that. Okay. Next. There we go. We have evidently a lot of questions. I'm sorry we're talking over a little bit here. There's my number. I didn't put all 4 regions up, but I certainly can give you that if you have additional information. If we can't get to some of your questions, feel free to email me if you want. Okay, thank you.
So we're going to start here. This is going back to what the waiver cannot pay for, and the question was, you can't pay for home repairs even if they are done during a crisis time and are proven to be a danger to the person if they are to live there in that environment before the repairs are done.
If I got your question, if I'm interpreting it correctly, that there are some things that if it's an adaptability or accessibility piece, those repairs can be done. In some cases, it may be that we have to look to state dollars and some other areas of getting that kind of support. The waiver will not cover home repairs. It will if it is an accessibility or adaptability issue.
Okay, and then a follow-up to that is what type of accountability being held to those that are to help those find employment or work towards looking for employment?
I mean, that's an excellent question. We're always looking at accountability. Part of the key to some of our accountability is service coordinator has the responsibility to at least annually assure that the person has the opportunity to review or show that they are getting the services that they are requesting and that is being paid for. They also do some audits, and they're getting a little more widespread. We started them with what we call community-supported living arrangements. But that annual IP review, or any time a team meeting needs to come up, and the audits that we conduct are a beginning at getting at that accountability.
Okay. Do we have new resource coordination agencies in Anne Arundel County?
Do we have new? No. For Central Region, all of service coordination, or all resource coordination is conducted through Service Coordination, Inc. Some of you may know that the state of Maryland is working on a redesign of what we call service resource coordination, and how it looks may be very different than it does right now. But in Central Maryland, of which Anne Arundel County is, Service Coordination, Inc. is the provider.
Okay. You had listed, you had said something about support brokers, and I also have that question. What is a support broker?
A support broker gets real confused with a resource coordinator. It is specific to the new directions. It's part of the guidelines. The support broker can be, in many situations, a family member, or it can be from a list of designated support brokers that really serve as a one-to-one support for that person. New Directions tends not to be a provider-driven process, and so families or the person can be pretty much out there alone, dealing with some of the coordination needs, advocacy, some of the Medicaid compliance pieces. Support brokers' roles are to help make that happen.
And Chiquita asked the question, I just have to explain it. Is New Directions sort of a replacement for DOORS, or is there a replacement for DOORS?
No. DOORS is a standalone, separate system. New Directions is really just an additional option that the state of Maryland developed so that there would be your more traditional, comprehensive kind of waiver, and then New Direction with slightly different federal guidelines to it is more self-directed. So you have more flexibility in how you spend Medicaid funds, but with that flexibility comes a whole different set of responsibilities and accountability. So it's really just an additional alternative within the DD system.
Okay, and you have to pay a percentage to a support broker if not a family member.
Support brokers generally are paid, and even if it is a family member, they tend to have a rate put in there for the support broker. I believe, if I'm not mistaken, most of them are by an hourly rate, and there's a range. There's like a max, and then there's the usual range. So yes, that is a cost to the person's budget. That budget, by the way, a New Directions budget, one of the caveats is you're probably already receiving Medicaid services through Community Pathways. Your New Directions budget cannot exceed what your Community Pathways budget was costing.